Good morning, everybody. Thank you for joining us here today. My name is Chad Worley. I am the physician liaison for the Lurie Children's, or for the service area of the city north and the north and northwest suburbs. And we are here for the pediatric roundtable with the Lurie Children's Division of Gastroenterology, Hepatology, and Nutrition. I'm here with Dr. Barry Werschel, who's going to be your host today, and he'll be introducing all of our physicians throughout the day. But before I turn it over to Dr. Werschel, I just want to let you know that we have a few brochures that are available in the handout section that you're able to download, and I will also be emailing them out when I send out the link to the recordings for you today. We'd like to encourage questions in the question room and the chat room. I'll be monitoring those, and then after Dr. Fortunato's presentation today, I'll be asking the questions to Dr. Fortunato or any questions you have for Dr. Werschel today. And then one last thing before I turn it over is that we do have a poll and survey questions for you, if you don't mind answering those for us after the end of the program. We'd appreciate it. But without further ado, I'd like to send it over to Dr. Werschel, and he's going to go ahead and get things started for you. Dr. Werschel, take it over.
Great. Thank you very much, Chad. Good morning, everyone, and welcome to this pediatric roundtable with the Division of Gastroenterology, Hepatology, and Nutrition. I'm Dr. Barry Werschel. I've been at Lurie Children's now for 13 and a half years. It's been a pleasure to serve as the chief of the Division of Gastroenterology, Hepatology, and Nutrition. I come from Washington University, where I got my medical degree. I did my pediatric residency there, and then I did my fellowship at the combined program in pediatric gastroenterology at Harvard. I spent more than several years on the faculty at Harvard before moving to New York and subsequently here to Lurie Children's. The opportunity here has been exciting and invigorating and challenging, and has given us the opportunity to build a really world-class division here at the hospital. And some of that is reflected in the program today. I just want to mention the fact that we are consistently now ranked as one of the top programs in the country by U.S. News and World Report, and the highest ranked pediatric GI program in Illinois. At the present time, we have, and I'll have to kind of go around the slide to make sure I have the right number, 23 attendings. We're about to add 2 more to provide some of the subspecialty services that we provide at the hospital. Along with the physician cohort that we have 11 nurse practitioners or advanced practice nurses that work alongside us, providing care for patients that we see at 12 different sites that are listed there. I also wanted to highlight the fact that while we have an advanced endoscopy program at the Maine Hospital, and by advanced I mean we're taking care of children with variceal hemorrhages, special bleeding problems, patients that require ERCP and various other procedures that cannot be done at every facility. We do have 2 outpatient surgical programs that run both at Northbrook and Westchester that allow us to do more routine upper endoscopies and colonoscopies on patients within their neighborhoods. So the program today, as I say, kind of reflects some of the subspecialty things that we do, and also some of the things that are very important to you as practicing pediatricians. And rather than go through the entire format, I'd just like to kind of kick it over to Dr. John Fortunato. John is the head of our motility program, also known as the Neurointestinal and Motility Program, the NIM program. He is a graduate of Tufts. John has a very interesting history. He went into general surgery initially, wised up, and did a residency in pediatrics at Johns Hopkins and a fellowship in pediatric gastroenterology at Johns Hopkins. We were very fortunate to be able to recruit John to Lurie Children's. He's a national and internationally recognized expert in problems of motility and functional GI diseases. And today he's going to be talking to us about when should abdominal pain be called irritable bowel syndrome. And with no further ado, I'll kick it over to John.
Perfect, thank you. Well, I can't think of a better way to start the week than to talk a little bit about irritable bowel syndrome, so we'll get things started. Okay. And just to make sure, Chad, can you see my screen? I just took over. Okay, hopefully
yes.
You can.
Yep, looks great, thank you.
All right, thank you. Just to be transparent, I have no conflict of interest or financial disclosures. So we want to talk about irritable bowel syndrome today, but I think really to get a better understanding of the approach to this and how to define this and really frame this, you really need to look more globally at functional gastrointestinal disorders. The second goal for today really is to underscore this whole biopsychosocial model of care for these patients. It's certainly not a straightforward black and white type of diagnosis, and because of the comorbidities that are associated with them, it really is important to take a more, dare I say, holistic approach to patients, looking at all aspects in both diagnosis and treatment. So irritable bowel syndrome as a functional disorder, the primary goal, of course, is to look at this today as the Rome-4 have classified irritable bowel syndrome. We'll get to that in just a moment. And then I think we use that kind of as a tool towards understanding the mechanisms, underlying symptoms. And I think that's important both in terms of the approach to the patients and really understanding the rationale behind different treatments. I really would like to introduce the notion of using symptom questionnaires as a tool, as an instrument toward defining patient phenotypes. And I think we'll find even with IBS itself, it's not just one particular condition. And then try to tie this together and how it relates to the treatment. Yep. So to start, just as far as definitions, functional disorders. This is a slide I think I stole from one of my colleagues a couple of years back, but it really underscores what they are and what they aren't. First of all, they're non-organic. It's not necessarily a biochemical, mechanical issue. It's not a psychiatric disease. And I think one of the things that's important to underscore is this is not patients making up or symptoms or faking conditions. We define this as the body's normal activities, motility, sensation issues are impaired, but there isn't a discrete abnormality that can be identified on testing, blood tests, x-rays, and endoscopy, which again makes it all the more challenging because the patient's symptoms can be pervasive and debilitating. So functional disorder is a symptom-based diagnosis. And we say the mechanisms are unknown. We've postulated the idea of motility issues, inflammatory issues, or even nervous system issues, central, peripheral, autonomic. At the end of the day, the etiology of the cause is not clear, but certainly has a major impact in terms of life events, quality of life. Oftentimes when we talk to patients, symptoms are triggered or exacerbated by an acute event, such as an infection or inflammatory issue. And then there's, again, the perfect Venn diagram of psychosocial issues and potentially genetic predisposition. So not to speak light of it, but it's as clear as mud. So again, I'm gonna probably go through this talk saying why is it important, and I'll get to that with this slide. But I think one challenge, of course, is the patient population. The presentation is heterogeneous. It would be a lot simpler. Patient had pain, one spot, we treat it, and we reassess. But it's a very broad, diverse group of symptoms of chronic symptoms in our patients. And like I said before, there's not a clear biochemical or structural abnormality. But again, the reason it's important, whether these are the patients that can be time-consuming, exhausting, both for families and for clinicians. But it's a large part of our patient population, both in general pediatrics and in pediatric gastroenterology. And in terms of putting the significance to it, this is not a child or adolescent with tummy pain. It has an implication. Yeah, these data actually, in terms of the cost, are extrapolated more from the adult population. Unfortunately, as we know, it's always difficult to have more objective data in kids. But when you start looking at the cost of functional conditions like nausea and vomiting, or in the adult population, irritable bowel syndrome, we're talking in the billions of dollars per year. Now, in the adult population, we think of lost time at work, lost activities, But it translates over into pediatrics. These are the parents that are missing work, that are bringing the kids to the ER. So it really does have that downstream effect in terms of the health system. And so just to start with this model of care, this biopsychosocial model, it really encompasses this conglomeration, if you will, of looking at both the physiologic issues, pain, modulation, autonomic, motility issues, even the intestinal microbiome is certainly a growing area of interest in terms of pain and irritable bowel syndrome. The hypotheses and evidence that come out are real time. Again, even from our standpoint on a research end of things, we're looking at categorizing patients and looking at different avenues to explain the potential, again, physiologic causes behind pain and other functional conditions. But you have to put that in the context of the other aspects that affect pain, the emotional aspect. And I think that's one part that we often talk about, the chicken and the egg, are the anxiety and depression issues a consequence of longstanding symptoms, or do they pre-exist, or how does that integrate into it? And the way I've described to patients, it's more of a three-dimensional versus linear model. Unfortunately, all these things don't go one after the other. We have to look at cognitive issues and then environmental circumstances. And I think you've probably seen this in a lot of your patients. A lot of patients we see, particularly with not just refractory, but more challenging symptoms, tend to be high-achieving patients. And so when you put that in the context, patients who have potentially underlying anxiety issues, high stress, high achievers, it's a component towards really framing a treatment plan. So this is really meant to be more the disclaimer slide. So when these patients come to the office, come to your office, there's certainly the red flags that we always want to underscore when we talk about these patients. So patients who have weight loss, for instance, blood in the stools, bilious emesis. This is a litany of things that really warrant a more robust investigation before making it almost a default diagnosis of irritable bowel syndrome or other functional disorder. So these are the things that warrant consultation, that warrant a conversation. And I put it out there just again, because these are the things that we need to address first, because if there is a discrete inflammatory bowel issue, for instance, or a surgical issue or other metabolic issue, those are things we really need to address before we go to the functional diagnoses. So I put this slide out here just to kind of emphasize the discrepancy, if you will, between adults and children. And we see here, this is a little bit old, this is probably about a year old now, when I did a PubMed search just for curiosity to see if I just typed in irritable bowel syndrome or chronic abdominal pain, what the numbers look like. And what this should sort of present is that the literature is voluminous, but disproportionately in the adult population. And I bring that up because, we always say in pediatrics, children aren't necessarily mini or little adults. I mean, there's a lot of both diagnostic approaches and treatment approaches that are extrapolated from the adult population. But again, there are other circumstances, and we're talking about really different patient models. So I put it out there, and hopefully those, as time goes on, those numbers will continue to rise, particularly in the pediatric population. So just to give some sense of things, in terms of the epidemiology, when we look at some non-US studies, in terms of school-based studies for the prevalence of IBS, it's been estimated in the 5% range. What's interesting is in the US, it's been estimated by parents in the 1 to almost 3%. I would challenge you that those numbers are probably underreported, partly because we haven't had necessarily a discrete questionnaire or mechanism to actually assess patients. So I would imagine that even though we're talking 3%, there are a lot more patients that probably have symptoms that would qualify as IBS if they actually went through a more rigorous assessment. So in terms of the subtypes, irritable bowel syndrome comes with constipation or diarrhea, or unspecified. And that should in itself, again, emphasize the fact that in some ways you're almost talking about 4 diametrically opposed presentations. So again, just in terms of the epidemiology, when you go from one end to the other, are we talking about the same condition? Are there other mitigating factors? Really, what is this condition? And so that's my transition into Roman. I'm just going to keep an eye on the time, because I want to give full 10 minutes for questions. So the Rome Foundation, this is something that was a nonprofit that was developed back in 1989, and it's a international expert panel. And I think the important thing to emphasize is it's a consensus model for defining functional disorders, including IBS. Consensus, so there is evidence, but this is really a group of experts and professors coming up with a general consensus in terms of what defines these conditions. So it's a guide. It's not perfect. It's not a treatment algorithm per se. One of the things that's interesting relative to a couple slides ago is the Rome 4 actually has separate adult and pediatric recommendations. That wasn't always the case from Rome 1, 2, and 3. As recently as Rome 3, there was a sliver for pediatrics, and the rest was adult. So we've come a long way in terms of actually understanding that we really are talking about different patient populations. Again, these are symptom-based criteria, and there are actually are diagnostic questionnaires as part of this that actually help us define both IBS and other functional conditions. So just to get down to sort of the brass tacks of irritable bowel syndrome, it's defined at least by Rome 4 as abdominal pain at least 4 times a month. It's related to pooping, to defecation, with a change in the frequency of the stool, change in the form. And you kind of saw that from the way we were talking about this in a previous slide. And it's interesting when you bring the poop into it, for children that are constipated, the pain doesn't resolve after resolution of the constipation. And last but not least, the last disclaimer is the symptoms can't be fully explained by another medical condition. So again, it's a guide, but you could tell from this, there's a lot of room for interpretation. And so it helps to kind of frame irritable bowel syndrome after a thorough workup, after we've ruled out the red flag symptoms. Last but not least, I did mention this, is that the criteria have to be fulfilled for 2 months before diagnosis. So again, 2 months versus 3 months versus 1.5 months. It is a consensus just to keep a consistent algorithm for assessing these patients. And again, it helps us as a guide to understand these patients, particularly as we look at treatment strategies. So we've talked about this a little bit before. What causes functional disorders? Are they the same as motility problems? I think I've already answered, is there one phenotype condition or several? And I think the most important thing that I can really pass along to is, what does it matter? And this is one of the major reasons why it matters. Unfortunately, a lot of these patients with chronic pain are again, dare I say, over-tested. We've had several patients come into our clinic after gallbladders have been removed, 2 or 3 colonoscopies, and other procedures. And I think it's important to take a step back for a moment to think about, again, the sort of the risk-benefit ratio in these patients. So a lot of patients do undergo invasive tests, especially when they come to the ER. I think more than a couple of our patients have had at least 1 CAT scan. And so from an endoscopic standpoint, and we looked at this recently in another patient population in our group, but endoscopy itself demonstrates abnormalities, generally speaking, 25, 50%, and I would even go so far as to say, not to say abnormalities, but findings. And just an endoscopic finding doesn't necessarily translate into a cause of the underlying symptoms. We actually looked at this in patients with chronic nausea and found that the positive rate for a colonoscopy was less than 10%, and for upper endoscopy somewhere around 30%. So the problem is the hammer and nail approach. Again, since I've been on both worlds, in surgery and in GI, surgeons do like to operate. I can attest to that. And gastroenterologists do like doing an endoscopy. But the question is, what is the patient population that's going to most benefit from this kind of testing? And so this is where I think it is important just to touch upon the mechanisms. And so when we kind of put this all together, there is the possibility, although it hasn't been completely defined, that there are genetic predispositions for some of these patients that could set the stage in the context of a triggering event. So for instance, an inflammatory issue, motility disorder, distension. But then you have to put that together in terms of the psychosocial aspects, or pre-existing anxiety and depression, family issues, abuse issues, and stress. And this sort of all comes together toward a debilitating abdominal pain. But what's interesting is this also translates into this notion of changes, not just in pain, but in the processing and visceral hypersensitivity. And I'm just going to quickly show you just a little bit of our data, just for no more than 20 seconds. We actually did a study looking at patients with chronic nausea and autonomic issues for a year duration. And we actually found changes in neuroconnectivity in patients who actually had autonomic symptoms and GI functional symptoms. My point in this is again, not to belabor lots of functional MRI scans, but yes, your brain does change functionally in the context of longstanding symptoms. And that's, again, really sort of underscores again that biopsychosocial model of care. It's not just the gut. Otherwise, I think all of our jobs would be a lot easier. So I think the other thing just to mention with these patients is they are very aware and become increasingly aware the more they see consultants and doctors. You know, when you walk out of a procedure and say, oh, things look good, you don't have a problem, go back to your doctor. And the absolute worst possible thing to say is it's in your head, go see a psychologist. To me, we've incorporated a more integrated model in our clinic with having psychology work in partnership with GI, but not as a substitute for the gastroenterologist. So when you say those things, you have things come crashing down. And in the interest of time, I'm just going to go through this a little bit quickly. But again, one of our goals, certainly in our program, is defining the patients. We mentioned before that the symptoms are heterogeneous. If you want to define the phenotype, you got to ask the right questions. So one of the basic tenets in our program is a battery, if you will, of questionnaires that are tailored depending on the symptoms of the presenting patients and the age. So for instance, we look at autonomic symptoms. We have actually a defined validated nausea profile. We look at the functional symptoms. We actually do measure quality of life, and we look at anxiety and depression. We look at sleep patterns. And again, not every single patient gets 200 pages of questionnaires. We really try to frame that, again, based upon our initial review of an intake that patients send us before clinic. Because again, from the standpoint of how we can really best work as consultants to you, understanding the patients before we schedule the appointment, knowing really what needs to be involved in that appointment, I think is key towards really an effective visit. We're actually starting to incorporate what David Sell and his group have actually developed here at Northwestern, the patient-reported outcomes measures. This is actually a part of our routine testing now. We use this really, again, particularly from the psychosocial angle of things. We do have a psychologist that reviews our questionnaires before our patients are seen to look for risk factors, including psychological and mental health concerns. And to put it in perspective, and I'll quote the patient since it's a little bit harsh. So what I found, adolescents were getting frustrated, or at least one adolescent, about stacks of paperwork. I mean, the notion of a fax machine, I mean, my kids don't even know what a fax machine is. And so to quote a kid, in terms of these questionnaires, he said, these suck, make an app for it. And we thought, well, once our pride sort of came back online, you know, there was a precedent for this. Our adult colleagues have developed apps towards more optimally engaging patients. And we've started to do the same. And this is some of our initial work that was supported through a device grant a few years ago. And we're trying to optimize this notion of user-centered design, involving the patient, involving the provider, towards really what's the best way to capture symptoms in a way that's not a painful process. I think we all know from an adherence standpoint, if you give someone 100 pages of difficult questions, they're just not going to do it. And so really we're looking, as we go through iterations of this process, how can we really better collect these symptoms in a way that's, again, not just less painful, but even potentially somewhat productive and, if you say, enjoyable to the patient doing them. So in the last few minutes, I just want to quickly touch upon the treatment. And I think the fact that we talked about there is not a clear black and white mechanism, you know, when you've ruled out or at least assessed the red flag issues, the first thing is reassurance for patients. It's not meant to say that the symptoms are not important or not concerning, but to take a breath before we jump to 20 more tests. And again, eliminating that fear, which oftentimes exacerbates the symptoms both for patient and family, it's really an important part toward okay, this is how we're going to approach things, and really defining a timeline and milestones for the treatment plan. Again, I can't say enough that I think validating that the symptoms are real, but not necessarily dangerous, is important. And it really is for both parent and patient. Anyone who has kids knows that if there's underlying concerns that continue to fester, it just creates an overall environment of stress even at home. Again, the biopsychosocial approach, I think, is sort of the testimony to that. One of the difficulties we have is, patients would love to have one pill make symptoms better, but unfortunately, there really isn't strong evidence for specific medical treatments for irritable bowel syndrome. Again, like I said before, a lot is extrapolated from adults. And I think it's important to weigh that risk and benefit. I mean, there's a lot of new surgical procedures, pacing, and new meds that are trialed in adults. I just think we need to keep in mind the safety aspect of things and really what is the response we get. We do empirically try medications and after a discussion with the patient and family, and it really needs to be a joint decision, because the analogy I've given in the past is when someone has appendicitis, we don't ask you, do you want to try this treatment? It's a black and white circumstance. With this, because we're treating symptoms, what is the impact? What are the side effects of medication? What's the response relative to the benefit? There are out-of-the-box treatments, biofeedback, relaxation, family therapy, CBT, and again, this really, I think, just emphasizes our need for having psychology involved, not as substitutes, but as collaborators. We actually looked at dietary issues. We actually have a dietitian involved in our clinic as well. And again, we do consider ourselves only as good as every member of the team that works with us. There's fiber that can be addressed, and also empiric elimination of foods like lactose and gluten. So I think I'm getting close to time. So just to sort of tie this together, the functional disorders, irritable bowel syndrome, unfortunately, they're prevalent, but it's a job for all of us in terms of how we work together with these patients. The morbidity is not insignificant, and the impact on quality of life and function is also a major issue. The causes are probably multifactorial, particularly with the diverse presentations, and unfortunately, there's not one test fits all. Really, to understand these conditions, it's important to understand the constellation of patient symptoms as they relate to a phenotype. Again, asking the right questions gives you a basis for a treatment plan. ROM4 is a diagnostic guide, helps to frame it, but doesn't necessarily tell us what to do. It's important to address GI and non-GI questionnaires because of these coexisting symptoms, psychosocial, autonomic. That by having this data, it helps us to sort of, again, point us in the right direction toward where we start and where we potentially hold or table for a period of time. And I think really it's important listening to the patient. So maybe the notion of making an app for that, aside from being told off by a 15-year-old, is not a bad idea. And I think really this integrated model versus the siloed clinical approach, both within our team and both as we partner with providers outside, is really key toward taking care of these patients. So this is another slide I stole from one of my colleagues. So, but really, like I said before, we do function as a team, both within the division and within our own program. And if you want to go it alone or go as a team, I think we've been more effective in caring for our patients and addressing questions, working in this multidisciplinary approach. I think that may be the last slide I have. And I'm sorry if I went over a bit.
I think it's great. I think you did a great presentation, Dr. Fortunato. So thank you for all you've done here. So I'm going to bring in Dr. Werschel as well. And we have a few questions. I'm going to go ahead and put up a quick, Dr. Werschel, want to put up your slide? I'll make you a presenter. And all right, so questions in right now. So first one, do patients who were born premature have more issues with the GI when they grow up?
A lot depends, number one, on how premature and what the actual issues are from being premature. For instance, children who have central nervous system issues or even autonomic impairment early on can have long-standing issues from a GI standpoint. Again, those patients are a very unique group. There is really no such thing as a 24-week premature infant that has a completely easy, straightforward course. So I think the answer to the question is quite possibly depending on the circumstances around the time of delivery, how premature the child was. Yes, certainly we take care of children with neurocognitive issues, cerebral palsy, who certainly have other issues. For instance, refractory constipation issues, feeding issues. So yeah, I think the easy answer is yes, it's a potential problem, but it's so individualized depending on the circumstances relative to prenatal and postnatal circumstances.
Okay.
I think it's a very interesting question. Understand that, John mentioned things like the microbiome, and I'll mention things like the developing immune system within the gut. So you have these very young infants who are seeing a lot of antibiotics, who are seeing feeds to a gut that isn't necessarily mature, and an immune system that certainly hasn't matured to the point of being able to recognize and tolerize to foreign protein. So it's a very difficult and has to be a very long-standing linear study to be done. But I think that there are multiple aspects of what happens in these particularly very early, these very premature infants that could potentially play a role in both food allergy as well as functional GI diseases.
Okay.
But to date, when people have looked and looked at populations, and John, you can correct me if I'm wrong, they really haven't identified a particular subset of premature children who go on to develop some certain types of GI or functional diseases. The only caveat to that has been some studies that have been done with food allergy.
Yeah, from a neuro-GI standpoint, again, I think this gets back to the whole thing about really phenotyping the patients, because there are certain patients who are premature because of genetic predisposition issues, and that goes down different avenues. So I think there are a lot of avenues, and I guess the really key point is, for better or for worse, it really does require going through a meticulous timeline of events. As a general rule, our clinic tends to be we tend to have a little more time for patients, just because there's a lot to sometimes unpack in those circumstances, and so we really start from point one to the current visit. So yeah, that would be the only thing I would add to it.
Okay. Well, we have a few other questions that I want to in here that I would like to get to. Dr. Taji, thank you for always presenting great questions for us. Here's another one. How is the vascularity of the gut as visualized on the endoscopy vary with whether the patient was born prematurely when grown up?
I'm sorry, I didn't hear the first part of the question. I thought you said vascularity.
Yeah.
Yes, that's correct. How is the vascularity of the gut?
Yeah, I think, as I make sure I understand, I think from this, I have not necessarily seen discrete differences in the endoscopic vascular pattern. I mean, there certainly can be vascular issues related to other consequences from prematurity. Barry, maybe you can comment. I don't.
Yeah, I can. First of all, we don't do a lot of endoscopies on neonates or prematures. In fact, we try very hard to avoid such kinds of activities because they're very high risk, and the scopes aren't really developed for premature infants. Vascularity has a very limited scope when you're doing endoscopy, because you cannot. All you can see are vessels present, or are they obscured? And generally they're obscured by either edema and or inflammation. So we can't really discern a pattern of vascularity, only the presence or absence of vascularity when we're doing endoscopy. And that doesn't speak at all to anything beyond the mucosal vascularity, because that's all we can see is the mucosa.
Yeah, I think, from the standpoint of kind of the vascular, I was thinking about this for a moment. This tends to be more of an issue that comes up with some of our adolescent patients with pain, and certainly I don't want to go down the rabbit hole of conditions like medial ligament syndrome or MALS, but this is something from a more global standpoint. Again, it's a area of research that's not well defined, and that's where, to Barry's point, when there are concerns from a vascular flow issue, ultrasound, duplex ultrasonography tends to be more helpful in those circumstances. But for infants, again, I rarely do endoscopy on babies unless there's a bleeding issue or a more acute issue where we can actually, number one, define it an objective problem, and number two, treat it as well. So from that standpoint, yeah, it's not something I necessarily see as a tight connection with prematurity per se.
Okay. Well, we have several more questions I'd like to get to here. So, Dr. James Olson asked, I've seen VSL complex probiotics used for IBS with some success. Any studies support this?
As a general rule, there is fairly robust literature in terms of the impact of probiotics and improvement in symptoms. In terms of what's the best probiotic, there's more on Lactobacillus GG, that just by virtue of it being around longer. Again, I don't mean to sort of diminish it to say, well, it is empiric or trial and error, but to some degree it is, because again, what are we treating with a probiotic? And we talked about this before, as far as the microbiome being a potential issue. If we all had a perfect signature of the genes and the bacteria in our colon, we could really more specifically target a specific probiotic. So the answer is, number one, yes, there is reasonable literature in terms of the impact of symptoms for probiotics. Number two, is there a specific probiotic that's better than the others? Not really. And number three, I think the more we begin to learn about the specific mapping of both genes in your poop, in the microbiota of the colon, I think that gives potential targets to be more specific. But again, we're still at the point of actually treating symptoms based upon patient presentation.
Okay, well, thank you for that. And then Dr. Chabda asked, any thoughts on fussy baby and IBS? What is the minimum age at DX?
The minimum age, what was that?
It says, what is the minimum age at DX? So I don't,
Well, again, I think, so for one, it is a kind of a difficult line, in terms of the fussy baby versus the fussy toddler versus the school age child, adolescent. And again, this does kind of connect to the whole microbiota. Babies are basically developing the bacterial composition of their colon. And so I can't say that I've actually labeled too many infants under 12 months as IBS. I think that's really more of an evolving process relative to their bacterial development in their colon. So I think that would be the first thing. I think just in terms, well, I think I'll stop with that for just a moment. I really tend to be more focused on the nutritional aspects and feeding tolerance and with parents. With a fussy baby, unfortunately, there's a spectrum of presentation. Some babies are eaters, some babies take a while. A lot is contingent on their tolerance of feeds and how they're growing. So I don't necessarily label infants less than 12 months of age with IBS. I think there's more refractory or persistent symptoms, either number one, despite formula nutrition changes, or persistent beyond the age of 12 to 24 months. Then I get a little more concerned about that being an issue. But I don't. I would say a very small patient population, at least in our group.
Oh, I'll be a little more definitive. I wouldn't think about IBS in a child less than 4 or 5. You have to really separate out children who are having, abdominal pain and absolutely no changes in their bowel habits from those. I mean, because there's as practicing pediatricians, this has been known for 70 years that functional abdominal pain, the 5-year-old who's having separation anxiety because they're being sent to kindergarten, all of these issues are being pushed earlier on these children, and their response when they're upset, when they're anxious, can be, my tummy hurts. So it's really, I think you have to be very careful about labeling kids with a chronic condition like irritable bowel syndrome when they are very young. Irritable babies, irritable toddlers, start to think more about protein intolerance and how they're processing the things that they're eating, rather than thinking about that they have a chronic condition, which theoretically, if you have not theoretically, in practice, if you have irritable bowel syndrome, you have that for your life. And that's one of the things that patients have to come to grips with, is that this is a condition, not necessarily a disease, and it's manageable. But as soon as you start thinking about it in these younger patients, you're potentially leading them down a path it's going to be very difficult to redirect them. So I think that, you know, the concept of that John laid out and the Rome criteria are really critical in that sense. There'll be constipated kids who have abdominal pain and don't have IBS. So remember that, you know, and if you treat the constipation and the abdominal pain gets better and the constipation gets better, that child doesn't have IBS.
I think the last one, and you brought this up as well, is the dietary part of things, particularly for infants and toddlers, because that's something that, again, part of the reason why it's such a key part of the history. You know, there are fruit juices, things like that, that parents sometimes are giving to kids, you know, particularly in the toddler years, that can have an impact in terms of gassiness and symptoms. So, you know, again, I'm a little more, keep a broad perspective, but by a similar token, yeah, it's something that know your dietary history in patients, what the parents are doing, what the circumstances are. And I think, again, the key point of treatment is reassurance. We don't like to test these patients in general, or certainly over-test anybody. So I completely agree.
Well, that's a great transition into our last question here that we're going to get to. And the last question is, how many tests or what tests you want us to do as pediatricians before we send you patients?
That is an excellent question. So I think in general, a lot is contingent on the presenting symptoms and those red flag symptoms. So for instance, if a patient has abdominal pain and change in stool patterns with weight loss, then I think it's certainly reasonable to send some basic labs, CBC, a metabolic panel, to start. I think if there's some suspicion of weight loss and change of stools and a concern for something like celiac disease, that's something, to me, that's a reasonable serum test to send from the start. But it really is contingent on the symptoms, on weight loss, on other symptoms that really are outside the box of irritable bowel syndrome. I think that those, to me, are the simple tests to start to rule out more specific concerns. Again, and I use the
about calprotectin, John.
What's that?
You want to say something about calprotectin?
Yeah, slippery slope with calprotectin. I think it's depending on someone's level of comfort. When you have a patient that's presenting with abdominal pain and loose stools, of course, you know, the concern comes up. You know, it's not IBS, but inflammatory bowel disease. I think it's important whenever we order a test, if you're comfortable with the outcomes of how that dichotomizes patients, I think it's reasonable to do. I think it really is at the level of comfort for the provider. We do tend to have a low threshold to do calprotectin. I use it as a guide towards, am I going the more not invasive, but the more diagnostic route? I think it really is contingent on your level of comfort with that. It's a helpful tool, especially when it's elevated. However, there are other mitigating circumstances. Not all elevated calprotectin translates into chronic inflammatory bowel disease. So I think putting that in context with the duration of symptoms and the red flags, to me, is really vital towards having meaning.
Just so everybody's aware, you know, calprotectin is a fecal test. It's a protein that's released by mostly neutrophils, but it can be released by other inflammatory cells as well. And an elevation of the calprotectin is in the stool is suggestive of some type of inflammatory process. But when you look at the results from a calprotectin, it's generally broken down into normal, intermediate, and abnormal. And the intermediate is where you kind of get into this fuzzy zone of is something going on, is something not. Understanding that simple things like excessive ingestion of Motrin, or doesn't even have to be excessive, it just has to be taking non-steroidal anti-inflammatory drugs can elevate your calprotectin. So there are things that you have to consider in the context of obtaining a stool calprotectin, but certainly a negative stool calprotectin in a patient with abdominal pain, loose stools, weight loss can be reassuring that the patient is unlikely to have inflammatory bowel disease.
The one last comment I'd like to make is the poop part of things, towards not just necessarily a test per se, but just part of the physical exam that's key. So in a patient that has loose stools, oftentimes, I mean, it can be from diarrhea, from an inflammatory event. It can also be from an overflow issue, particularly for patients who have a large stool burden. So as a general rule, I'm old school. I percuss every belly that I see. I push on every belly. The rectal exam is certainly an area that sort of tests our relationship with patients, but it is really important because when you have a patient that presents that way, there's tests like calprotectin, there's X-rays that can look at stool burden. But at the end of the day, if there's a concern, is this an inflammatory issue? Is it an overflow issue? Which again is relevant towards the treatment strategy. It's not necessarily a test, but it's a diagnostic part of the physical exam. A rectal exam is actually very helpful for us to know, particularly for patients that have had longstanding symptoms where we're trying to differentiate overflow versus inflammatory diarrhea versus other.
Okay, this has been a great discussion today. So between your presentation, the lively questions, and discussion afterwards, this has been wonderful. So I just want to thank everybody for joining us today. And you can reach Dr. John Fortunato. He sees patients in Lake Forest, Lincoln Park, and Skokie, and of course the Maine Hospital. And you can also email him at jfortunato@lurie.org. Reach them through Rapid Connect or Epic in Basket. But on behalf of the Lurie Children's GI team, I just want to thank you for joining us, and I hope you come back on at 10:30 when we introduce Dr. Saheed Mohammed, the Medical Director of Hepatology and Liver Transplantation, as he'll be talking obesity and the liver, growing epidemic of fatty liver disease. And Dr. Fortunato and Dr. Werschel, would you like to say any closing remarks?
The other thing I would say is except from the standpoint of our approach, our team's always happy to reach out and answer questions. We try to again keep that connection with community and outside our program. So we look forward to talking to you.
Yeah, and I think I failed to mention the fact that John leads one of the larger motility programs in the country, and that we have the only full service motility program in the state of Illinois. So really, there is no greater expertise that you can obtain than from Dr. Fortunato and his group. We're very fortunate to have him in the division.
We really are. So once again, thank you everybody for joining us today. Thank you, Dr. Werschel. Thank you, Dr. Fortunato. And we'll see everybody at 10:30.
Take care.
Have a good day.